Thank you very much. So I will talk a bit about what we do to try and help us to determine how pituitary tumours will behave. So this is a brief overview of what I'll be covering today. So I'll talk a bit about pituitary tumours and how we define them, which is always changing, which is why I've included it. Clinical presentations and the factors that we use clinically to help us determine how these tumours might behave. Radiological factors that we look at, and then post-operatively, obviously, we have some histopathological factors that we can look at. From this, there have been various scoring systems that have been built, or algorithms that help us to predict long-term outcomes, and this is an area that we're continually working on, and in fact the area of my PhD, which I'm currently doing. So briefly, an introduction. Pituitary tumours are very common. They occur in approximately 1 in 1,000 persons. We define pituitary adenomas as benign, slow-growing tumours of the pituitary gland. Aggressive pituitary tumours are defined by their rapid growth and/or their lack of response to our conventional therapies. Pituitary carcinomas, on the other hand, as you can see down the bottom there, are defined by their distant spread of disease. Pituitary adenomas account for about 85% of these tumours, whereas aggressive pituitary tumours account for up to 15%, depending on the literature that you read. And pituitary carcinomas are exceedingly rare, accounting for only 0.1 to 0.2%. There are various challenges that we face in identifying the tumours that will behave more aggressively than others. The reported numbers of aggressive tumours vary very widely in the literature, and that's at least partly because there isn't a clear diagnostic criteria. So the diagnostic criteria that I talked about on the previous slide is very clinical and subjective to interpretation. There are, however, various clinical, radiological and pathological factors that we can use to help us predict how these tumours will behave, and I'll talk about those during the course of my talk. And then we're currently engaged in, at the Garvan, further research into biomarkers that could help us predict the long-term outcome of these tumours, and that's a really exciting area of research. So whenever we talk about disease states, I think it's always really helpful to remind ourselves of what normal should look like. So this is the normal anatomy of the pituitary gland, and I think the really important factors to appreciate here are its close proximity to really important structures in the brain. So just above it we have the optic chiasm, and then on either side of it we have really important blood vessels and nerves that can be impacted by its growth. The normal physiological actions of the pituitary are wide and varied. I like to call it the hormonal control centre of the body. So it secretes growth hormone, which in turn stimulates production of IGF-1, prolactin, which leads to breast development and milk production, ACTH, which we've just heard about, leads to cortisol secretion from the adrenal glands, LH and FSH, which act at the gonads to stimulate production of sex steroids, and then TSH, which acts at the thyroid to stimulate production of thyroid hormone. So when we think about pituitary tumours then, we can either think about too much hormone production, not enough hormone production, mass effects, as we've just looked at, and then much less commonly, distant spread of disease. Clinical presentations vary widely. We can have hormone hypersecretion syndrome, so growth hormone secreting tumours, ACTH secreting tumours, and TSH secreting tumours. And those are treated with primary surgical therapy. Prolactin secreting tumours tend to respond exquisitely well to medical therapy, and so we treat them medically in the first instance. And then we have those tumours that are clinically non-functioning or that don't produce any hormones. And they may or may not have mass effects such as visual defects, headaches, and deficiencies in other hormones. And depending upon those, we may or may not consider surgery as primary treatment. There are other factors within clinical presentation that can help us to determine how pituitaries will behave over time. We know that younger age is associated with aggressive behaviour. There are common local mass effects such as headache and visual field defects that can occur both in benign tumours as well as in aggressive tumours. And then there are very aggressive mass effects that we know are generally correlated with poorer outcomes. And those are the things such as cranial nerve abnormalities and also hydrocephalus, which is increased fluid in the brain, generally caused by a blockage. So the first thing that we do generally is look at a radiological assessment once we've assessed the biochemistry, of course. When we look at radiology, we've defined macroadenomas as tumours that are more than 10 millimetres or 1 centimetre in diameter, and microadenomas as those that are less than 10 millimetres in diameter. We know that microadenomas very rarely progress to become aggressive tumours or pituitary carcinomas, but some macroadenomas may respond exquisitely well to treatment and may not progress to become aggressive pituitary tumours or pituitary carcinomas. We then also look at tumour invasiveness. We have various criteria that we look at radiologically that helps us to grade this, and one of those is the modified NOS criteria, which I have illustrated here. Basically, it's a graded measure of tumour invasion that you can see there as to how far it spreads outside of its normal area. With increasing radiological grade of the tumour, we know that that leads to increased invasion that the surgeons observe when they're operating. And we also know that that leads to decreased chance of complete resection and/or of hormonal remission. This is an example of a tumour that is very obviously aggressive at the outset. And so although size doesn't always predict outcome, when we observe these really aggressive growths into surrounding tissue there, you can see it's gone right into the brain tissue. We know that those types of tumours generally behave very aggressively over time. We can also look at tumour growth over time, and this is particularly relevant for non-functioning tumours, where if they're not having particular mass effects, we might decide to watch and wait and observe with serial MRIs over time. The rapidity with which a tumour doubles or changes in volume over time unfortunately varies widely and is not very predictable. But what we do know is that if it grows very rapidly, that generally is a hallmark of an aggressive tumour. So that usually rings an alarm bell for us that we need to act aggressively in response. We can also look at factors within the radiological imaging and density that help us to predict how tumours will behave. In particular, an example of this is in growth hormone producing tumours. We can look at the actual density. So on the left here, you can see the tumour appears darker when compared to the normal brain tissue, and that signifies a lower T2 intensity, which is associated with a densely granulated somatotroph or growth hormone producing tumour. On the right, we have an image of a tumour that appears lighter when compared to the rest of the brain tissue, and that's representative of a higher T2 intensity, and that represents or may represent a sparsely granulated somatotroph tumour. And sparsely granulated somatotroph tumours are known to behave more aggressively over time, and they're also known to respond less well to treatment. So that can be a really important key for us into how we approach this particular tumour. And then, of course, post-operatively, we can then look at anatomical pathology and different biomarkers that might help us to predict how the tumour will behave after that. And that becomes really important at our multidisciplinary meetings when we sit down and discuss how we'll treat this patient from here on in after the operation. We have proliferative markers, which are basically a marker of how quickly the cells within the tumour are proliferating or how quickly the tumour is growing. Ki67 is an indication of tumour cell growth and proliferation. It's measured by an MIB antibody. Here you can see on the left-hand side a tumour that doesn't have much reactivity to the MIB antibody compared with the right-hand side, which does. And so that would signify to us that that tumour might have more proliferation. We have various cutoffs that we use as hints, basically, as to how these tumours will behave over time. We know that a Ki67 of greater than or equal to 3% is associated with aggressive behaviour. And here we have some numbers. So 81% of aggressive pituitary tumours will have a Ki67 that's greater than or equal to 3%. And 85% of pituitary carcinomas will have a Ki67 that's greater than or equal to 3%. And then when we have a very high Ki67, so greater than or equal to 10%, that doesn't diagnose pituitary carcinoma, but it certainly makes us concerned about it. So then we start looking much more carefully at these tumours over time to monitor for deterioration. The other proliferative marker that we use is something called mitotic count, which is the number of cells that are dividing in a certain amount of tissue. So a mitotic count of greater than or equal to 2 per 10 high-powered field. High-powered field is just an area within the microscope that we're looking at, is suggestive of potential aggressive behaviour. So 63% of aggressive pituitary tumours will have a mitotic count that's greater than or equal to 2%, and 90% of pituitary carcinomas will have this. And here you can see in the image, the arrows point at cells which are currently dividing, so those are the ones that we're counting. The WHO, or the World Health Organization, in 2017 released a new classification of pituitary tumours. They suggested that we start classifying pituitary tumours according to their cellular lineage, and that cellular lineage should be diagnosed by transcription factor analysis, which I'll talk a bit about on the next slide. The other factors that we look at in predicting outcome are, as I've just talked about, Ki67 and mitotic count. So during pituitary development, there are specific transcription factors that are fundamental to the complex process of cell differentiation. So from precursor cells here on the left, such that they become corticotroph cells, so ACTH producing, somatotroph cells, so growth hormone producing, lactotroph cells, prolactin producing, thyrotroph cells, TSH producing, and gonadotroph cells producing LH and FSH. And these transcription factors, so TPIT, SF1, ER alpha, and PIT1, help us to identify those cell lines or cell types with excellent precision. So by analysing those now, we're able to really be very sure about the type of cell that we're looking at within a tumour. This becomes really important and relevant in certain tumours that may or may not express hormones very well. So we've talked about the non-functioning tumours or the silent tumours that don't produce hormones, but they may in fact come from a certain cell lineage and have those characteristics of that cell lineage. Down the bottom here we have some nice graphs from this study where they looked at silent pituitary tumours, so those that were not producing any hormones clinically. And they looked at their transcription factors, and what they found was, in actual fact, 73% of them were gonadotroph tumours, 16% of them were corticotroph tumours, so ACTH tumours, and 9% were PIT1 positive tumours, so of the growth hormone, prolactin or TSH lineage. That really helps us to predict how those tumours might behave over time, because even though they're not producing or expressing the hormone, they might in actual fact behave a little bit more like the tumours of that cell line that do produce the hormone. And that's an area that I'm really interested in researching further and forms part of my PhD. This is basically just an example that exhibits the same thing. So here we have a gonadotroph tumour, so LH-FSH line, that didn't show any positivity to the FSH-LH when we looked at staining for hormones, but it was very positive to the SF1 transcription factor here, and that confirms that cell lineage, whereas before measuring the transcription factors we might not have been able to appreciate that. Having these transcription factors plus the proliferative markers plus hormonal immunoexpression helps us to identify certain aggressive subtypes of tumours, and I'll go through a few examples of those. So we have PIT1, which is one of the transcription factors that I've talked about. So plurihormonal PIT1 positive tumours, which are positive to one or more of the hormones of that cell line, as well as PIT1. We know that these tumours behave aggressively. We've already talked about sparsely granulated growth hormone tumours, so we might see some changes on MRI imaging that relate to those tumours. And then when we look at them under a microscope, the sparsely granulated there is appreciated on the right. And then we've talked about the ACTH tumours, or the silent ACTH tumours, which don't produce the hormone but have the hallmarks of an ACTH tumour on microscope examination, and those tumours we know to behave aggressively over time too. There's also Crook cell pituitary tumour, which basically has these round sort of hyaline cartilages that are seen under the microscope, or ring-like hyaline bodies. And then there are a number of emerging markers that we look at and that we're researching with our team. And these form an extensive list, and I'll be looking at some of them with my PhD, and some other members of our team will be looking at others with their PhD. And basically we look at markers of pituitary differentiation, oncogenes, so that stimulate tumour growth, and tumour suppressor genes, which generally would suppress tumours, and if they're not functioning well, tumours are allowed to grow. Next thing we do is look at post-operative review. So when we do our multidisciplinary meeting, we obviously do an MRI after the operation, and we can look at whether there's any residual tumour or not. So we know that tumour recurrence is predicted by the presence of a remnant. It's also predicted by the location of the remnant and the remnant growth over time. And that's, of course, why we monitor with MRI over time. So if we then think about putting all of these factors together, we have the radiology preoperatively, and we have any evidence of invasion that might point us towards an aggressive tumour. Post-operatively, we have all of these anatomical pathology factors, and then we also have radiological imaging over time. This Trias classification was released a few years ago now, in 2013, and is basically what we use at the moment to help guide us into the future. So we look at the tumour diameter, we look at whether it was invading different structures, and we look at presence of proliferative markers like I talked about, Ki67 and mitotic count. And then this brings me to the topic of my PhD, which is looking at personalised medicine for non-functioning tumours. This is my PhD team, and we'll be speaking later, of course. And what we're looking at basically is developing a more comprehensive predictive algorithm that would involve some of the clinical factors that we've talked about, the radiological factors, the proliferative markers, but then with the addition of the cellular lineage that we've talked about, and also some of those novel and fascinating biomarkers. And that brings me to the end.
I can understand because you're doing your PhD, you have to be across all of this stuff.
Yes.
But how would a poor endocrinologist who's seeing people, how could you be up to date with all this stuff that's just coming out in such quantity?
In fact, that's part of the reason why we'd like to form this predictive algorithm, because hopefully that would allow all doctors to look at quite a simple tool, plugging in a few factors, and from that be able to predict an outcome quite easily without necessarily being across everything. So we can be across that little bit and provide a tool to the other doctors that is hopefully easy to use.
It's really interesting research that you're doing. I'm really fascinated. Is there anything that's coming out with what's actually causing the tumour? Because there's not, like, we see a lot of stuff about the different categories, and I know that's your focus, but are there any driving factors, like we talked about the genes potentially, but are there any other factors that we're aware of that could cause, or is there any research being done in that?
Yep.
In the cause?
The biomarkers that I talked about in one of the final slides, in fact, are looking at that pathogenesis. So we're trying to understand the pathogenesis of pituitary tumours better than we do. At the moment, there has been some research into that area, and we certainly have some understanding of some of the pathways and genes that are involved, but we don't have a very comprehensive understanding in all cases. We've been able to, some genetic research has been able to identify certain cases, and it's been a lot of case studies so far that have identified pathogenesis in small groups of tumours, but we haven't understood it all to put it all together yet. And that's certainly a very interesting area for future
There's not
research.
a lot of information, my research shows there's not a lot of information available on it.
Yeah, that's actually absolutely
Is that correct?
Yeah.
So, as a layperson, are you saying it's genetic? Are we saying it's always genetic, or is it sporadic, or what? I'm a layperson.
Of course.
Who's had 2 operations
Yeah.
for it. So.
Yeah. In some cases, we think that it's genetic, and in some cases, it's completely sporadic that we know of at this stage.
Can I say I come from a town which has got a lot of cotton, so we have a lot of chemicals. we have a high rate of cancers. Is there anything that's trying to sort of put the environment with these?
There certainly is thought that epigenetic factors and environmental factors may determine tumour outcomes and drive tumours, but we haven't got a good understanding of how and if that is occurring. And like I said, we know that there are certain gene mutations that are associated with pituitary tumours. There are some that we haven't identified a genetic abnormality. That's not to say that there isn't one or that there aren't factors that we haven't identified.
I tend to get them later in life, so I'm wondering how they're genetic or more sporadic, getting them later in life.
It's a good question that we don't know the answer to well, unfortunately. A lot of them are sporadic, we think, but more research might tell us differently in the future.
Thanks very much for your presentation. But for those of us who have functioning pituitary tumours, I just wondered what research has been done on, so I've had a recurrent one, treated with radiation, so I've got a compelling interest in any diagnostic tools that can use earlier data or monitoring it as to recurrence. And just following on from this woman's question, in terms of ACTH, I just wondered whether, given that the Atlanta Centre for Disease Control has an enormous database on adverse childhood experience, and whether I'm just making a wild leap to cortisol and stress, whether in an epigenetic sense, children who've had childhood trauma are more likely to have a ACTH tumour, or whether there's no way of knowing that. But my major interest is any research done on how to monitor the signs that would indicate, given they're invisible to the MRI, indicate recurrence, and therefore do something that could manage that.
I don't know of there being any causative link there. I don't think that there has been one identified. Again, that's something that's incredibly hard for us to ever really research well, because they're such rare tumours, and establishing that sort of causation is very challenging. It's not to say that it has nothing to do with it, I don't know. To answer your second question, a lot of the things that I've talked about here are applicable to both functioning and non-functioning tumours. And so the study into particular biomarkers in particular will be relevant to both functioning and non-functioning tumours. Looking at transcription factors and cellular lineage in that way is also very helpful for functioning tumours, in terms of being very sure of our diagnosis and also identifying certain transcription factors and characteristics that might be associated with aggressive behaviour. So it's definitely a growing area of research with many people who are very interested in it, including myself. I've focused on non-functioning tumours for my PhD, but I'm broadly interested in the outcomes of all tumours. And I know that our group is researching that a lot, and there are other centres within the world that are also researching it currently, so it's definitely a growing area.
I just want to say that I've had a pituitary tumour for a few years, and thanks to Dr. McCormack and Dr. Winder, it's been removed. And but the thing is, can you say that sugar is kind of one of the causes for these tumours to actually develop? Or because I've just found that I've kind of cut down on my sugars, and it's helped a lot with the weight and things like that as well, but also with the pituitary tumor.
I'm not sure what type of pituitary tumour you have, sorry.
Adenoma.
Okay. Non-functioning, was it?
Are you okay for me saying? I mean, you're ACTH.
Okay. That type of tumour actually can make management of sugars hard. As we've heard, it can push the sugars up in itself. As to whether it's a cause of the tumour, I don't think so. I don't think it has anything to do with it, to my knowledge or understanding. And
in terms of improving your management, I think cutting down on sugar is certainly a really good, excellent, healthy diet and lifestyle are always just good for general health. I don't know that it will actually impact on the pituitary itself, but that's not at all to discourage you from continuing to pursue that.
Gigantism
Yes.
is acronym from child,
Yes.
being a child. So that would discount the head trauma whole picture, wouldn't it? Because is that from a tumour as well, like gigantism? Is that's
Yeah, gigantism is essentially caused by a growth hormone tumour that happens during childhood, so before growth, normal growth has finished.
Yeah.
Correct.
And cats have them as well. Cats have big.
Yes.
It's crazy.
It is.
Some people have
Sorry, another question. Obviously, this fascinates me. Like in the life of a tumour,
Yes.
can we actually see it change from secreting different hormones? So could it start out potentially as I don't know, ACTH, and then
Excuse me, can you speak a bit louder?
sorry, I'm speaking to the microphone. So do you see changes? Do you see it evolve from maybe secreting ACTH, is that right, to then maybe becoming a prolactin secreting? Does it evolve? Have you examined that?
That's a really excellent and interesting question. And although it doesn't happen commonly, it can happen, and we have seen it happen. There are case reports of tumours like that. In particular, that may begin, for example, as a silent ACTH tumour. So if we were to examine the transcription factors, it may actually have the transcription factors that mean that it is an ACTH tumour, but it's not producing any hormones. And then over time, it might transform to become productive to releasing ACTH. So we have seen those sorts of things. We can also see a mixture of cells within tumours. So sometimes we have growth hormone and prolactin secreting tumours together. There is also an evolution over time. So sometimes tumours will start out as looking like a fairly benign tumour, and then over the course of time become more aggressive or undergo a period where suddenly they become very aggressive. And that's something that we don't understand well, and that we're very interested in understanding better as to what triggers that change. And often that change is associated with poorer prognosis, whether it be a new hormone production or new rapid growth.
Thanks.